Hello, everyone. So me and Jack are going to present the Mind USA study, which was a paper printed out in the New England Journal of Medicine in 2018, December, looking at the use of haloperidol and ziprasidone, which is an atypical antipsychotic for the treatment of delirium in critical care illness. So just a bit of background. We know that delirium is a syndrome which is characterized by these 6 features, predominantly disorganized thinking, fluctuating mental state, acute mental status changes, inattention, psychomotor disturbance, and disturbance in cognition. And why is this important? Well, we know that patients in the critical care setting will experience some form of delirium. That's usually between 30 and up to 80% of our patients, with the higher end of patients being those that have been intubated, ventilated, and on sedatives and strong pain, analgesic control. Now, there are 3 main types of delirium which are covered, broadly speaking. Hyperactive delirium, which is the one that we tend to focus on quite a lot, and we manage with different sorts of medications, predominantly antipsychotics and sedatives. We also have hyperactive delirium, and lastly, mixed delirium. Now, when we talk about delirium and assessing it, we use the CAM-ICU, which is the confusion assessment method for use in intensive care unit. Now, we've got this on our charts on the right, on our daily review charts that the consultants fill out. But also what it actually is when the nurses each day in the morning, so at least once during a nurse's shift, they're supposed to go through this. So the first step is to access the patient's RASS score, and it needs to be between -3 to +4. Once that's the case, then you can proceed to do your CAM-ICU. The first step is to assess whether there's any form of acute onset or fluctuation course, and this is from their baseline, what that normally is. And if there is one, then you move on to the second step, which is inattention, and they have to squeeze the hand every time the letter A comes on. And depending on the number of errors, you move on to the third step, which is to assess the level of consciousness with your RASS score, and finally, whether there's any evidence of disorganized thinking or not. So if your score is positive, if your CAM-ICU positive, that means delirium is likely in place. And if it's negative, that means it's unlikely that there is delirium. Now, what our guidelines, which were done by Dr. Mlanjam and Dr. Oldrum and revised in 2018, have this flow chart in place, where just touching on what your RASS score is, and then if your CAM-ICU is positive, what are the next steps? So it says non-pharmacological management is quite important. It should be your first step. Following that, if that does not work, then we go on to pharmacological options, with our first line being haloperidol, olanzapine, risperidone, and quetiapine. With risperidone and quetiapine, I haven't seen that being used very much. And then second line, we've got your clonidine and dexto as well. And chlordiazepoxide can be there as well. And note that we don't have any benzos on this point in time. And we should be avoided if possible. And why do we care about delirium so much? So we know that it's linked to a longer period of mechanical ventilation, and makes it more difficult for patients to wean from the ventilator. This in turn leads to patients having a longer hospital stay, needing more rehab, and leading to also further cognitive impairment in the long-term run. And lastly, delirium has been linked to higher risk of mortality. Now, just focusing on antipsychotics for the use in delirium. So guidelines from the Provision of Intensive Care Service 2016 say that there is currently no evidence to support the use of antipsychotics in critically ill patients, either to prevent or treat delirium. Currently, antipsychotics should be reserved for the management of acute agitation. So then this begs or leaves the question as to why do we use antipsychotics to treat delirium? So this study, Mind USA, aims to try and come up with evidence to suggest whether haloperidol or ziprasidone, which is an atypical antipsychotic, reduce the risk, the duration of delirium when compared with placebo in delirious patients in the intensive care unit. Now, the study itself was a randomized double-blinded trial. It involved 16 intensive care units in the United States over a period of about 8 years, beginning in 2010 to 2018. And patients were determined to be either delirious or not using CAM ICU over a 5-day period. Once patients were identified, they were then randomized on a one-to-one basis, either into the placebo group or to receive haloperidol or to receive regular ziprasidone. So in terms of inclusion of the patients, so patients who were included in this study was anyone who was above the age of 18 and needed respiratory support, which was either mechanical or non-invasive, or required cardiovascular support being an intra-aortic balloon pump or vasopressors. And patients who were excluded were those who had a poor cognitive impairment, breastfeeding, pregnant, or at high risk of side effects of antipsychotics, predominantly cardiac, such as prolonged QT or any neuroleptic malignant syndrome, or those who genuinely had allergies to these medications. So when we talk about our patients who were included in the study, so 20,914 patients were assessed for eligibility for the study. Of these, 16,306 were excluded from the study, leaving 4,608 patients remaining who could have partaken in the study. So of those 4,608 patients, a large significant proportion of them declined to be part of the study. So 74% of the patients declined, which left us with a total number of 1,183 patients who could have provided us with informed consent and could have gone further with the study. Now, if we look at those patients who could have partaken in the study, the 1,183, we note that from those, although they fulfilled the criteria for being part of the study, a lot of them were excluded because you needed to have, once you were consented into the study, you needed to have delirium within the first 5 days of being consented. Other patients, although they were consented into the study, did not develop delirium, so they were excluded, or they were discharged from intensive care unit before the 5-day period, and some of the patients died as well. Although patients were meant to have been excluded prior to this stage, some patients still had cognitive impairment or had changes on their ECG long QTc, which excluded them. So this left us with a total of 566 patients, which could have been randomized into either of the 3 arms. So from the 566 patients, they were randomized roughly equally across all 3 arms, with 184 patients being randomized into placebo and 192 into haloperidol, and lastly 190 patients into the ziprasidone arm. And just looking at the demographics of the patients who were involved in the study, so they were predominantly median age was 60, and it was split roughly 50-50 between males and females. And importantly, if we look at the type of delirium that the patients had, in this study, we note that across all the 3 arms, most of the patients had a hypoactive delirium, with on average about 11% actually having a hyperactive delirium, which we'll touch on a bit later on. And in terms of the actual illnesses that were going on that brought patients into the intensive care unit, so it covers all across the board, whether it's your respiratory causes, your infective causes, whether it's your surgical causes. So that's quite a good representation of the population that we get in our intensive care unit. And lastly, about 92% of the patients who were randomized were invasively ventilated, with the remainder being non-invasively ventilated.
So to take it up from here, so the interventions, so the arms that were being randomized to, you had a haloperidol group, so that's your typical antipsychotic and the antipsychotic that probably we see used most in our ITU, and that was administered intravenously. So all 3 drugs were administered intravenously, starting at 2.5 milligrams if the patient was younger than 70 years of age, and 1.25 milligrams if older than 70. And then as per sort of BNF, maximum of 10 milligrams in one administration and 20 milligrams per day. Ziprasidone, being another arm, is a similar antipsychotic to the one that we use in our guidelines, which is olanzapine. The mechanism is slightly different, but we can kind of loosely compare it because it's an atypical 2nd generation antipsychotic. That was also administered intravenously. And the control group had an intravenous placebo. All 3 were colourless, which followed the double blinding. And then management common to both groups, as just mentioned, identical bags, clear in colour, administered at the same time. So that was twice daily, which I'll come on to the relevance of that in a minute. And the drug dosage was titrated according to symptoms. So depending on their CAM ICU, if delirium carried on, then the investigators would double the dose. So your initial dose in the morning of 2.5 milligrams of haloperidol would become 5 in the evening. You'd titrate up and down by doubling, if that makes sense. So the primary outcome, which was number of days alive without delirium or coma during the 14-day intervention period. So once they'd been randomized and started receiving haloperidol, 14 days thereafter, we found, or the study found, there was no significant difference between the 3 arms. So ziprasidone, for us, we're comparing that loosely to olanzapine. So ziprasidone, haloperidol, and placebo all had around about 8 days of delirium. And the p-value was 0.26, so there was no significant difference. And the secondary outcomes found no statistical difference between the 3 groups for 30-day mortality, 90-day mortality, time free from ventilation, ICU discharge, readmission, hospital discharge, safety endpoints, and death at 30 days. So no difference between the 3 groups, placebo, haloperidol, or ziprasidone. So in conclusion, this paper stated that there was no evidence that the use of haloperidol or ziprasidone, so your typical and atypical antipsychotics, had any effects on the duration of delirium among patients with acute respiratory or shock in the ICU, so our general admission cohort into ICU. So what were the strengths? The strength of this study was that it was a multi-center study across 16 centers in America. There was a broad inclusion criteria which represented most of our patients who were admitted into ITU. An intention to treat analysis, so once they started, we carried on with recording the data for the 14 days. And studied both a typical and atypical antipsychotic in a double-blinded method. So they were the strengths, with a very large cohort as well, 20,000 started. What weaknesses were there? The risk of selection bias due to a significant number of consent refusals, so 3,425 individuals of the original 20,000 included either didn't give consent themselves or had an advocate not give consent. The majority of patients, so Ishay touched on this, had hypoactive delirium, so 89% of the 500 that were treated for delirium had a hypoactive delirium. So in our experience in ITU, we tend to see hyperactive delirium being treated with antipsychotics, haloperidol or olanzapine. So how relevant that then makes this study to our practice is a question. It was studied in the USA. Their care delivery is different to ours, so there could be an issue with comparing the data to our population. And interestingly, in the 3 groups, so in the final 500 or so that were randomized, a rescue open label antipsychotic was used. So in 21% of patients. So whilst we were giving a bi-daily dose of haloperidol or ziprasidone or placebo, should they have a breakthrough period of acute agitation, an antipsychotic was used, which weakens this paper. Will this change our practice? So this study shows that there is no, or using haloperidol failed to improve the duration, timing and outcomes of delirium in our patients. So should we be using haloperidol? We currently use olanzapine, which is different, as I've said, to ziprasidone. Ziprasidone has a mechanism that targets dopamine receptors and serotonin receptors, whereas olanzapine covers more receptors. But I think as a 2nd generation antipsychotic, we can probably use it as a surrogate. Delirium is a syndrome with no single pathophysiology. So reasons for patients having delirium in our ICU is so multifactorial that the original indication for antipsychotics is for psychosis. So using them for delirium may not be entirely appropriate to treat the phenotype, as it were. The best treatment is to reverse the cause and establish anti-delirium measures. So I think that we could do far better in preventing delirium by encouraging a sleep-wake cycle, engaging patients in the day, allowing them to sleep at night, treating their pain. So doing all the things that are mentioned in our guidelines before delirium unmasks itself would be more ideal. But a role for antipsychotics, such as haloperidol, does remain for safety in acute agitation and as a sedation adjunct. So our references are on the slide, and if anyone would like to ask Ishay or myself questions, feel free.
I don't know if I missed this, but was it regular haloperidol or was it PRN?
So once a patient was randomized into a group, so for you to have been randomized into an arm, you needed to be either on respiratory support, either invasively or non-invasively, or had cardiovascular instability, needing vasopressors or intra-aortic balloon pump. If you fit those, and be above 18, if you fit those criteria, the next move was to randomize to gain consent. In gaining, once after consent has been granted, then every single day a patient would have twice daily CU monitoring. As soon as they become delirious or any features, CAM-ICU positive, then the patient was then randomized into an arm and they'll receive BD dosage. So once they've been randomized, then they'll get twice daily dosage
yeah.
of whatever drug that they're meant to be, whether it's haloperidol, ziprasidone, or the placebo. And according to symptoms, then the dose was titrated.
Okay,
and
cool.
by symptoms, it's your CAM-ICU. If you were negative for more than 2 days, they'll halve the dose. And if you're negative for more than 4 days, they'll stop completely the intervention. Whereas if you're positive for more than twice, they'll increase the dosage.
Thank you.
This is where that the haloperidol rescue part came in to sort of muddy the waters a little bit.